what a great meeting and what a fabulous session so far. I was just learning tons. We're moving on to bread and butter coronary PCI from shock, so severe coronary calcification, and over the next 10 minutes we'll go through some management options. Those are my disclosures. So, quick overview. The purpose of the talk today: how do we detect coronary calcification? How good are we at detecting it? How often does this happen? What are the implications? And what tools do we have to treat them, and how should we use them? And what's the data that using these tools helps improve outcomes? So detection. Of course, you can fluoro calcium. You can use intravascular ultrasound, or you can use OCT. On the left panel and on the right panel, you'll see what is defined fluoroscopically as severe and moderately severe calcium. So what they define as moderate calcium is calcium that's identified on a cine run during cardiac motion, whereas severe calcium is something that we see often in patients with renal failure, where you see a silhouette of the vessel, both sides, and usually seen on just stepping on fluoro. So what about the frequency? You see it a lot, and in fact, despite being an exclusion criteria in most studies, especially the pivotal DES studies, it was seen by the core lab in almost 30% of patients. In an acute setting, in the Acuity and Horizon study, it was also seen roughly in about 26 to 30% of patients. So moderate to severe calcium is a frequently encountered problem in the cath lab. How about using IVUS? The challenge with IVUS is lack of histological penetration into the calcium. So you see it as a dropout, as we normally see, but you can't really measure the thickness of the calcium or the mass of calcium. We assume that superficial calcium is usually thicker, but when you have a greater than 270-degree arc of calcium, it clearly shows it impacts how you do your PCI. What about OCT? Similar data that's emerging with OCT in terms of stent expansion and calcium arc. However, due to the lack of penetration of the OCT, once again, although you identify calcium, you really can't really delineate it due to the fact that it's lack of lateral resolution, even though the axial resolution is incredibly more than IVUS. What about the implications of coronary calcium? Coronary calcium clearly results in several problems, leading to, firstly, impaired stent delivery, decreased expansion, increased malapposition, and edge dissections. And we'll go over a case demonstrating that nicely. In turn, it impacts procedural success, and because of the things I said earlier, it can increase your procedural complication. Over time, due to inadequate mean gain in lumen, you're going to have impact on both stent thrombosis and late loss with restenosis. So what about stent expansion? So two good papers that looked at this. On the left panel, you have stent expansion and a correlation coefficient with an R of 0.8, which is a pretty strong correlation coefficient and a highly significant p-value, showing that as the arc of calcium increases, the stent expansion is reduced. And this was at atmospheres that ranged from between 14 to 16, which we would consider high-pressure inflations by most standards. However, when you started going crazy and went up to 20 or so, the correlation coefficient sort of decreased a little bit, but it still held true. On the other hand, if you use some sort of a debulking tool like rotational atherectomy, and you had greater than 270-degree arc of calcium, as shown on the panel on the right, you clearly improve your stent expansion capability. What about impact of calcium on stent thrombosis and restenosis? Of course, there are tons of papers that have looked at this, and I won't go into details. Here's the long list available for review that clearly impacts early stent thrombosis, both with BMSs and drug-eluting stents, as well as late restenosis. In ADAPT-DES, two-year outcomes related to target vessel failure was at least 4 percentage points higher in patients who had coronary calcium that was severe versus those that didn't, achieving a significant p-value. So we'll go back to a case example that I showed earlier. On the right panel, you had that right coronary that was felt to have moderate calcium. The LAD, which seemed to was more severely calcified. And we did this case, and it serves as a great compare and contrast of how you could have really solved some of your problems if you were a little bit more careful in assessing the calcification. So this was a case done after hours in my hospital a few months ago. So the right coronary was looked at and felt to be something that could be treated without any debulking. No imaging was performed. And angioplasty was performed with a 2.5 balloon. Expansion was thought to be adequate in the proximal vessel, and a DES was deployed. And I think it was a 3.0 DES that was deployed. And as you can see in the right panel, we have a problem. You're now sort of in a situation where is what I call stent regret. You have a freshly deployed stent with a hourglass. So I got called in once this occurred, and so we have availability of laser, which is one of your bailout situations in this case, where you would laser with contrast, as you can see in the left panel. And what we ended up having to do was literally step on the laser for about 3 minutes and interspersed with injections of contrast. And this was a 0.9 a Turbo Elite peripheral laser, which doesn't have a 10-second on-off that you can just stay on and hopefully get behind the undilated stent struts and modify it. And that's what we were able to do. And as you can see on the panel on the right, we end up successfully expanding the previously undilated stent. However, what we didn't realize was that we now had an edge dissection beyond where the stent was treated. So now we're chasing our tail because we used the laser, then we dilated, we post-dilated, and because of the calcium that was throughout the vessel, we now have an edge dissection. So then we have to get a guide liner in, advance the guide liner, pass the proximal stent, and put a new stent in the mid-right. And you can also see later that now there's this distal dissection beyond the second dissection. So the artery is sort of unzipping. And this is clearly a problem that could have been avoided if the case was handled better from the get-go. So now we have further edge dissection. Ultimately, 2 hours later, you end up tacking that up and taking care of it with 2 other stents, and finally ended up with a reasonable result. The same patient was brought back 2 days later to treat the LAD, and knowing what we had learned earlier, we decided we would debulk from the get-go. We ended up debulking with a 1.5 and a 1.75 burr, got a guide liner in, switched our wire out, and ended up putting in a long drug-eluting stent, as you can see. And with a 38 millimeter stent, we ended up having imaging it. There was disease extending all the way into the ostium of the left main. We ended up lining that up, and in a matter of literally 25 minutes, we're able to take care of the entire LAD and the left main without any issues in less than 100 cc contrast. And here's your result of the LAD. Looked optimal. Orthogonal images demonstrate that the left main looks great. We post-dilated it, potted the proximal left main with a 5.0 balloon with imaging help, and we ended up with a good result. So the lesson, again, is that atherectomy simplifies complex PCI. You end up using less contrast, less radiation. It makes the procedure more efficient. You clearly, if you identify it up front, you get adequate stent expansion. You get less edge dissections. It allows placement for longer stents, so effectively use less stents per case. However, there is no long-term data that there is improvement in TLR and TVR with the use of atherectomy. Thanks for my time.